Hello, welcome everyone to this introductory video to chest x-rays. This video is designed to give you a solid foundation and systematic approach to interpreting chest x-rays and things that you're going to most commonly see in your clinical practice. The objectives of today's talk are to first review the basic physics of x-ray and densities that you are going to see on a chest x-ray. We're then going to talk about basic techniques of acquiring a chest x-ray and things to keep in mind when looking at them based on the technique. We want to learn basic anatomy of a chest x-ray both on a frontal and a lateral radiograph so that we are comfortable interpreting those. And then we're going to develop a systematic approach to interpreting chest x-ray. And finally, we will end with some real-life case examples to try to put everything together. So why is it important that we're talking about chest x-rays in the first place? Well, we know that they have a very wide clinical application to a lot of different settings, both the inpatient and the outpatient setting, and it's the most common imaging test that's ordered. It's basically another lab value for a lot of patients. We can use them to evaluate things like shortness of breath, cough, suspected pneumonia, cancer, and that sort of thing, trauma, and the list goes on and on. How are we going to evaluate them? Well, of course, we're going to look at the different structures in the chest, and we're going to go over a detailed systematic approach and anatomy to make sure we're all familiar with exactly how to assess all the different structures in the mediastinum, the lungs, the bones, the soft tissues and upper abdomen, and that sort of thing. And as far as any sort of special preparation, well, one of the good things about the chest x-ray is that it can be taken on just about anybody. And really it just comes down to, are they ambulatory or are they bedridden, and whether or not they can stand up for a PA and lateral, or if they need to have a portable AP film that might be either upright or supine. Okay, so let's dive right in. This is a picture of a chest x-ray. There are various densities on chest x-rays that we will get into. And it's important to know that in order to produce an x-ray image, that x-rays have to be first generated by a tube or emitter. They pass through the body or various body parts and are then absorbed by a detector. The amount of x-rays that pass through various structures determines how bright or how dark the image is. The denser the object, the fewer the x-rays can pass through that object, and the brighter the image becomes. The less dense a structure is, the more x-rays are able to pass through, and therefore those structures show up black or very dark on a x-ray. For this chest x-ray here, we can see that the lungs are very black and the things like bones are very bright. The mediastinum, with a lot of other structures overlapping, they are a brighter color than the soft tissues around. And when we look at the different densities, you first have metal, which is going to be very bright white. Bone, like we can see the spinal column, the ribs, and the bony thorax is white. Then you have a lighter white, which are the soft tissue structures. So soft tissue and fluid both show up the same density on x-ray. So we've got some of the muscle, we've got the heart, the mediastinal structures. These are the brighter white. And then you've got the more of a grayer color, which is fat. And so we can look at various areas of fat that we commonly and normally see on a chest x-ray, including in the base of the neck, the supraclavicular regions. The subcutaneous tissues are a lighter gray than the muscle planes that we can see adjacent to it. So it's important to know that these areas are normal so that they don't get confused for things like pneumomediastinum or subcutaneous emphysema. And then finally, we have air. So those are going to be the blackest areas on the image, and including the areas off the field of view, off of the image, that are completely black because they're not being absorbed by any structures of the body. Important concept that I want you to keep in mind anytime you're reviewing a chest x-ray or any sort of x-ray for that matter is that when two objects are of a similar density placed right next to each other, you're not going to be able to see their borders. So we can see on this normal chest x-ray, we can see borders between the lungs and the heart, the bone, soft tissues, fat planes, and that sort of thing. We can look at this white circle here and have that represent, say, a lung nodule or a pneumonia. We can see the borders nice and clear on all sides because there's a different density or contrast between the adjacent structures. Now, if we had another mass or nodule come up right next to it, then we would, if it was the same density, we would lose the interface and lose those borders between there. So that's important to keep in mind when you're trying to localize things on a chest x-ray, like if it's right next to the right heart border, if it's abutting the pleura, those sorts of things. The most common views that you're going to order are the PA and lateral chest x-ray. If the patient is ambulatory in either the outpatient or the emergency department setting, these are the best views to give you the highest quality of a chest x-ray to identify the most pathology. The other most common view that you're going to see is the AP view, which can be performed either upright or supine depending on the patient's clinical status. We're not going to get into other special views and applications like a inspiratory and expiratory view or a lateral decubitus view for just now, but those are all possible applications when you're assessing things like free air under the diaphragm or a pneumothorax, that sort of thing that we will get into on another lecture. So the basic technique. So let's go over a PA view and how it is obtained. So we know that x-rays are labeled according to how the direction of the radiation beam is traveling. So in this representation, we have a model of a patient. We have a detector in front of the patient. We have a x-ray tube or emitter behind the patient, and we can see an x-ray beam being generated passing from posterior to anterior, traveling through the patient and being absorbed by the detector. Let's simulate a PA technique just looking at the heart for a model. So we're going to start off with the heart. We're going to put the detector very close to the heart because in a PA view, the heart is closest to the anterior chest wall and closest to the detector. You've got the x-ray tube behind producing the beam that's traveling from posterior to anterior, and this will produce a very accurate representation of the size of the heart. Now let's contrast that to a AP view. Again, we have the heart, which is further away from the detector, and we've got the x-ray tube that is now closer to the heart with the x-rays traveling from anterior to posterior, and these x-rays are divergent. So when that happens is you've got these x-rays diverging out and spreading out, resulting in magnification. The same concept applies to visible light when you are using shadow puppets, and you can try that for yourself, putting your hand further away from the wall or closer to the flashlight. When this happens, the structures that are further away from the detector will become magnified. And we can take that and apply it to a chest x-ray and look at the different changes between a PA and an AP view. So the image on the left is a PA radiograph. Things that are closer to the film are more true to size. So the heart is going to be smaller. The ribs are better defined because there are these anterior ribs that are closer to the film, and the overall quality is better. There's better expansion of the lungs, and all of these things allow you to see more of the lung parenchyma and therefore detect a higher level of pathology. The AP view tends to be underexposed, so not enough chest x-rays or not enough x-rays can pass through the chest, and therefore the image tends to be brighter. If the image were to be overexposed, the image becomes more black. This is sort of the opposite of what happens when we think about regular photography. Okay, before we dive into our approach, it's important to have a broad understanding of the types of radiation levels that we're dealing with here. When talking to our patients, we want to be able to give them some sense of how much radiation we're actually exposing them to. And this chart here shows the effective radiation dose for the most common exams. And we won't belabor and get too involved into the details or try to memorize these things. But what we are wanting to focus on right now is that chest x-ray produces about 0.1 millisieverts, which is the unit of absorbed dose that is commonly used. We want to keep this in mind that the background radiation that we get just from living is about 3 millisieverts per year. This can vary a little bit depending on your elevation, but this is what we are exposed to just by living on an annual basis. So a chest x-ray is about 0.1, and to put that in perspective, one chest x-ray is in the order of about 1 to 2 weeks of background radiation. If we contrast that to a body CT, on the other hand, it's more like a couple of years of low-level radiation. And again, don't get bogged down with the overall specifics of these or try to memorize these, but just have a general idea of what we're dealing with when we're talking to our patients about the types of the levels of radiation that we're. Okay, before we dive into a systematic approach, let's make sure that we are all familiar with the normal anatomy of a chest x-ray. So we're going to start off with this PA upright radiograph, and the first thing that we look at is the trachea. A little bit more inferiorly, we have the carina, followed by the left mainstem bronchus. Number 4, we have the left pulmonary artery. Number 5, we have the right interlobar artery. Number 6, we have the aorta. Number 7, we have the superior vena cava. Next, we have the right heart border, which is made up of the right atrium. Remember that the right ventricle is an anterior structure. And then next, we have the left heart border, which is the left ventricle. And just above that, we can see the left atrial appendage segment. And then more superiorly is the main pulmonary artery segment. Now, we want to keep in mind that the space between the main pulmonary artery and the aorta should be concave. This is referred to as the AP window. Any convexity here or prominence of this segment can be a sign of either lymphadenopathy or pulmonary arterial hypertension or another mass. Let's review the normal anatomy on the lateral radiograph, starting off with the trachea. Then we have the bronchus intermedius, the left upper lobe bronchus. Just above that is the right upper lobe bronchus. Posterior and superior is the left pulmonary artery, and more anterior is the right pulmonary artery. Above that, we have the aortic arch. Number 8, we have the superior vena cava over here. Number 9, we have the anterior heart border, which is the right ventricle. Number 10, we have the posterior heart border, which is the left atrium. And then number 11, we have the right hemidiaphragm. When assessing which diaphragm you are looking at, the most reliable method is to see which one continues anteriorly. The left diaphragm gets obscured by the left heart border, and you lose it here as it comes closer to the heart. The right diaphragm is also more commonly elevated compared to the left, but that's not always, and you can verify that on the frontal view. Now, going back to the hilar structures here, it's not so important that you know which vessel is which or exactly which bronchus is which, but the key point that you want to take home is that you are going to be seeing a few lucent circles or tube-like structures surrounded by relative dense structures, which are the vessels. And there's going to be a relative paucity of density here along the posterior and inferior margin. When you start to see these structures being completely surrounded, looking more like a donut, that is going to be a sign of a mass or adenopathy or some other abnormality that needs to be interrogated more. While we're here on the lateral view, a couple other things to point out are going to be these relative lucent regions behind the sternum. This is the retrosternal clear space. This should be normally very lucent, filled with lung. A similar finding is also here at the retrocardiac space, which should be relative lucent. When you're assessing the spine and the vertebral bodies, this should also become more and more lucent as you go inferior towards the diaphragm. If these spines get more dense, that is called a spine sign and is a sign of either some sort of opacity like a pneumonia, a mass, or some other process that is causing that density. Okay, so let's dive into our approach to the chest x-ray. Now, before we get started, the most important thing that I want to stress is that whether you're looking at a chest x-ray, a CT scan, or any other diagnostic exam, the most important thing is to find an approach that works for you, that you're comfortable with and that you're familiar with, and stick to it, that you can do consistently and repeatedly so that you don't miss anything big or any subtle findings. There are many different approaches that have been described about a chest x-ray interpretation, including the inside out, outside in, A, B, C, D, E, different things that you may have heard of. I've seen those letters taken out even further than that before also. Let's try to simplify things and keep it basic so that we don't get too bogged down with too many extraneous details that we lose sight of the big picture and the key concepts of what we're trying to evaluate. That being said, there are always a few technical factors that you want to take a quick second to make sure that you identify and that you understand so that we don't end up interpreting the wrong exam on the wrong patient. So you always want to look at the patient's name and the date of the study to make sure that you're actually looking at the current exam on the correct patient. Other technical factors that you want to take a look at are things like depth of inspiration. So you should have 9 to 10 posterior ribs, which are these more horizontal ribs. The anterior ribs are more vertically oriented, and you should see at least 6 of those. You also want to identify if the patient is rotated at all, as this can change the appearance of the size of the heart and other things. So the clavicles are the best thing to look at for that, and they should be about equidistant to the spinous process. Now, the next thing that we want to look at when you start looking at the chest is any sort of support lines and tubes, any extraneous devices or metal that the patient might have. So if they're intubated, if they have a nasogastric tube, chest tube, central lines, all those sorts of things, sometimes they can be subtle, and if you don't specifically look at them, they can be easily overlooked. Or if you don't identify the positioning of them, they could be malpositioned and you might miss it pretty easily. We'll go over in detail on another lecture specific positioning of all the different support lines and tubes. Now, after that, you want to look at the midline structures, so the trachea, starting off with the airway, following it down to the carina, and identifying the left and right main stem bronchus. Don't get confused if you see subtle tracheal deviation related to the left-sided aortic arch. In fact, if it's deviated slightly to the left, that could be a sign of a right-sided aortic arch, which could also be sometimes subtle. Again, you want to take a look at the mediastinal borders, the overall size of the heart, which should be about 50% of the size of the thoracic cavity from pleura, so that's the cardiothoracic ratio, should be about 0.5. You want to have a good appreciation for the hyla and taking a look at the AP window. And after that, when you start to look into the lungs, you can divide those into thirds. So you can have the medial thirds bilaterally, then you can have the middle third, and then the outer third. Now, it's important to recognize that in this inner third here, the hilar structures are going to be very prominent, the vasculature is going to be prominent, and as you go out towards the periphery, the lung markings are going to become less and less prominent to being very faintly visible along the periphery towards the pleural surface. From there, you want to take a look at the upper abdomen and diaphragm. While you're doing that, you look at the costophrenic sulci, make sure that they're nice and sharp on both sides, that there's no pleural fluid. And since we know that this is an upright film, you're going to look for any air under the diaphragm. You might see bowel gas that's dilated. So take a look at the upper abdominal structures to make sure that you don't miss anything, especially something critical like pneumoperitoneum. And then from there, you want to take a look at the bones, make sure that they're symmetric, look for any subtle rib fractures. Sensitivity of rib fractures on chest x-ray is not the greatest, but you don't want to miss them if they are present. And then after that, you want to go back over and pay special attention to any blind spots or areas that are commonly missed, like the hyla, make sure that there's no sign of adenopathy. Take a look at the mediastinal borders. There is a good article in Radiographics that talks about all the different lines and stripes including the right paratracheal stripe, and looking at these hilar structures in great detail to make sure that there's no sign of adenopathy or another mass lesion or that sort of thing. Other blind spots that are known are in the apices, so you want to always have take a special second look at the apices, make sure that there's no opacities, look at the edges of the film, make sure that there's no pneumothorax, and then again, the upper abdomen can be a place of commonly missed pathology if there is free air, for example. Okay, so let's put that approach into practice on this PA and lateral film. So let's first talk about the technical factors. First thing I notice is that this film has this round circle and these 3 metallic BBs up at the upper corners, and the BBs are layering dependently. That tells me that this is an upright film and that these are on the non-dependent portion of this cup. If this was performed as a supine exam, these would be layering or grouping centrally here in the middle. There's no significant patient rotation. The spinous process is about equidistant from the medial edges of the clavicles, and the lungs are adequately expanded. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9 posterior ribs. So now moving on to the support lines and tubes, there are none. I don't see any abnormal foreign bodies or metal objects or any tubes placed. Moving on to the trachea and mediastinal structures, the trachea is midline, the heart size is normal. I don't see any abnormal masses in the hilar structure. Keep in mind when we're looking at these structures, we're not only looking for size, but we're assessing things that are either too bright or too dark, whether those are foreign implants, clips, any evidence of surgery, as well as mediastinal adenopathy, other masses, abnormal convexities here at the AP window, and also things that are too dark. So things that are too dark could be a sign of gas where they're not supposed to be. So looking at the mediastinum, is that either pneumopericardium or is there a sign of pneumomediastinum? And I don't see anything that is too black around the heart or tracking up to the base of the neck. Again, we've got this normal amount of adipose tissue here in the supraclavicular regions that should not be confused with pneumomediastinum or subcutaneous gas. After we're happy with the size of the heart and the mediastinal structures, we will move our attention to the lung zones in a zigzag fashion, looking back and forth for any abnormal opacities. Consolidations are going to be fluffy, white, cloud-like, and more dense, versus interstitial opacities are going to be abnormal linear lines, smooth or nodular kind of band-like opacities. Again, we're dividing the lungs into thirds, making sure that the hilar structures are more prominent and that as you get out towards the periphery, the lung markings become less and less distinct. We're looking at the edges of the lung zones, making sure that there's no sign of a subtle pneumothorax. Again, since this is an upright film, it would be expected to be most noticeable here near the apices. We want to look at the upper abdomen. Again, since this is upright, if there was any air under the diaphragm, then we would see it collecting here under the diaphragm as a linear lucent band. Then we want to move on to the bony soft tissue structures around the chest wall. I don't see any broken ribs. I don't see any other masses or evidence of subcutaneous emphysema. I don't see any lytic or blastic lesions in the chest. On the lateral, again, we want to pay special attention to this retrosternal clear space, which is normal. There's this relative paucity of density here in the hilum structures. The retrocardiac space is also normal. The spine gets more and more lucent as we go inferiorly, and there is no sign of a subtle pleural effusion on the lateral radiograph. Again, we also want to look at the height of the bony structures on the lateral and any rib fractures that you may or may not see, or any compression fractures, as well as any sort of destructive osseous lesion. And again, just to reiterate, before we check off the film, we want to make sure that we've looked at the apices, all of our blind spots, give one extra look to the hyla, make sure that we're happy with that, and the edges of the lung zones, that there's no pneumothorax, and we're not missing any extraneous free air anywhere. Now let's apply some of these technical principles to this patient here. These are two images from the same patient taken one day apart, and these are both PA radiographs. Let's look at the degree of pulmonary inflation on the image on the left. So here we can count the ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, and just into that ninth interspace there, compared to the image on the right has 1, 2, 3, 4, 5, 6, 7, 8. So the diaphragm goes just above the 8th rib versus on the image on the left, it goes just below the 9th rib. And if we look at the cardiothoracic ratio on the image on the left, it is 0.45, which is within normal limits. And then if we measure that same ratio on the image on the right, it is 0.52. So did the patient's heart really become enlarged overnight? No, it just has to do with less expansion. The heart sits in a more horizontal position, and it is going to be overestimated on this image. Same way, if the patient was rotated, it would be a false measurement and would not be accurate. Okay, let's look at the following example now. Here we want to take a look at any technical factors. It's labeled as an upright AP film. So the lungs are underexpanded. I don't see any significant degree of rotation. There's no support lines like central lines or tubes inside the patient. We just have a couple of monitor leads that are external to the patient. And as we start assessing our mediastinal structures, the trachea here is deviated slightly towards the left, which should get your attention that there's some sort of opacity here to the right, whereas before when we went over the normal anatomy, we said that the trachea should normally be deviated slightly to the right because of the aortic arch. Now, if we file that away for a second and keep going, we notice that this left heart border looks very unusual and that the right heart border extends all the way towards the periphery of the lung. So now, the first thing that you should do here is go back and look at the label of the exam, and sometimes it'll be clearly flipped. Unfortunately, in this example, this was still labeled as being the right side, and so you have to be wondering, is this an incredibly rare case of situs inversus, or did the technologist simply mislabel and flip the image? Thankfully, in this case, we had an old exam with a prior radiograph that showed the correct orientation of the mediastinal structures with the correct labeling on the left side. You can imagine how, if you're not paying attention, this could lead to disaster. In this case, say if the patient had a pneumothorax, this would have been read out as a pneumothorax on the left, whereas it was really in the right lung. And if they needed a chest tube, the left lung would have gotten a chest tube inserted, which would have been the wrong side, which obviously would be a very major mistake and not something that you want to have happen. All right, now our next case, we're going to again look for any technical factors. You can see the arms are elevated with the clavicles high here. There's a few hair braids that are noted in the base of the neck. But otherwise, I don't see any technical limitations. The patient does not look rotated, and the degree of pulmonary expansion is adequate. Besides these hair braids, I don't see any other foreign bodies. There's no central lines or tubes. And as we are going down, looking at the trachea, it's midline. Aortic arch is here on the left. And we're looking at the right heart border, that's normal. Left heart border looks normal. The size of the heart looks normal. But as we're going up here, looking in the AP window, this segment of the heart, which is the main pulmonary artery segment, is convex, so it's enlarged, and that is a sign of pulmonary arterial hypertension. The lungs going through, they're otherwise clear, and there's no other abnormalities. So this is a young lady with sickle cell who actually has pulmonary arterial hypertension. On a chest CT, this is what the corresponding abnormality looks like. This is through the main pulmonary artery. We can see contrast in the main pulmonary artery and the SVC here. We're seeing it next to the aorta. the detailed anatomy of the CT can be further addressed in a later lecture. But for now, you can just use this to visualize how this convexity here can show up as a convex margin of this left heart border on the X-ray. Okay, next case. So we've got a portable upright film. The first thing that stands out to me is that the clavicles are asymmetric. The spinous processes are still relatively in the midline, but the left clavicle looks like it's basically being inferiorly displaced. And when we continue to look further, the trachea is also deviated to the left. We really have a hard time making out any of the right heart borders. We can see part of the right heart border here, and when we look on the left, we see a few faint calcifications in the aortic arch, and the left heart border is completely obscured. There is complete opacification of the left hemithorax with hyperinflation of the right lung. If we quickly go through and look at the right lung, it's otherwise clear. If you look very carefully here, and it's hard to see on this image, but there are a few surgical clips. Now, whenever you have a completely opacified hemithorax, you need to ask yourself, is this a volume losing process or a space occupying process? So is there something that's taking up space and expanding things outward, or is there volume loss and sucking things inward? And now in this case, it's pretty obvious that there is volume loss with retraction of the clavicle, displacement of the mediastinal structures in the trachea to the ipsilateral side. And if we take a look at the corresponding CT, we can see confirmation of that volume loss with elevation of the diaphragm, displacement of the mediastinal structures, hyperinflation of the right lung. And going back and looking at these surgical clips here, this patient had a left-sided pneumonectomy, accounting for all of these chronic changes. Now let's contrast that with this case. So again, kind of going through the technical factors, I don't see any support lines or tubes, a couple little markers that are here external to the patient. There's some scoliosis, but there is also, as we go down, we notice in the trachea is completely deviated towards the right. The right heart borders are also displaced to the right, so the whole mediastinum is being displaced to the right side, and we have complete opacification of this left hemithorax. So again, is this a volume occupying process or a volume loss process? So in this case, it's pretty obvious that there is a space occupying process here, producing mass effect on the mediastinal structures and resulting in some volume loss on this contralateral side. Now, if we take a look at the corresponding CT, we have a massive left-sided pleural effusion. Other things to consider based on the chest X-ray are things like a large lung mass. Even a pneumonia can cause some degree of mass effect, but not this much. So by far a large pleural effusion, what you would expect. And you can see part of this atelectatic lung here. And it'd be very difficult as you go through the rest of the study to see any detail of the lung. There could be a big mass sitting inside of the atelectatic lung that would be obscured because the whole thing is decompressed. And then you can see the volume loss on this contralateral side. Okay, so for our final example here, we've got a PA and lateral radiograph. And we will start off looking for any sort of technical factors and support lines and tubes. Again, all I see are a couple of monitor leads. The trachea is midline. The heart size looks normal. I don't see any sign of pneumomediastinum or any other abnormal gas tracking along the base of the neck. There's a few atherosclerotic calcifications in the aortic arch here. The hilar structures are within normal limits. There's a mild interstitial prominence bilaterally, which is often seen chronically with a little bit of bronchiectasis or bronchial wall thickening. And then as we interrogate the lungs, part of it's clipped over here, but there's no sign of a pleural effusion. Going all the way up here in a zigzag towards the apex, I don't see anything at the edges of the lungs. On the left, again, I don't see any pleural effusion or pneumothorax. However, when we get up to this upper lung zone, this area should stand out to you as being asymmetric. There is this rind-like opacity with central lucency and these fluffy areas of opacity and consolidation in the left apex. We can see corresponding abnormality on the lateral radiograph. Again, we know that this is going to be towards the apex and not anterior because we can see this retrosternal clear space is maintained. The retrocardiac space is preserved. There's some degenerative changes in the spine. I don't see any clear signs of adenopathy here. So we're left with this rounded mass with central lucency. So that is concerning for a cavitary process. So again, going back to our discussion of abnormal things that are too dark in the lung, being either pneumomediastinum, a pneumothorax, or something in the lung, you always have to think, is it coming from inside of the lung related to rupture or perforation of a internal structure? Like, did the lung collapse? Did the esophagus perforate? Or did it come from outside the lung? Was this trauma causing abnormal gas to get into the soft tissues or into the pleural space or mediastinum? Or could it be from something else, like a infectious process like necrotizing pneumonia, or a necrotic mass like a malignancy? So here, again, we know that we have this abnormality and we get a CT, and this is the corresponding abnormality on the CT. Again, we see this cavitary mass with some big irregular soft tissue density along the dependent margins of it, and this ended up being a necrotic lung cancer. Okay, that's it for now. We went over the basic anatomy and a basic review of the physics and applications of chest x-ray, how the images are acquired, which are important to understand why things look the way they do, if they're magnified, or where abnormal air might collect, for example. I really want you to just take home a good basic approach to reviewing a frontal and lateral chest x-ray, as those are going to be the most common things that you are likely to see and potentially have to interpret on your own before a radiologist might have a chance to look at it or get a report to you. I wanted you to have a good idea of what normal anatomy looks like, and just remember that practice makes perfect. The more cases that you see on a daily basis and consistently, that you will get better and better in finding these abnormalities. Develop a system and stick to it. Try to be consistent, and don't forget your blind spots. If you like this webinar and want more of these types of cases, there's going to be much more in the full course. That's going to be a comprehensive review of radiology, going over things from a patient-centered perspective with the referring providers in mind. We're going to discuss things like radiation risk, a lot of the physics and basic physics related to different types of modalities, including CT and MRI, ultrasound, and really hit the highlights to make sure that you understand what you're ordering for patients and have a good understanding of why certain things need contrast and when they don't need contrast, and just a lot of good information. And it will be accredited, so you will get your CME credits for that as well. Let me know if you have any questions. You can reach me at todd@medicalexpertsolutions.com for email, and I will be happy to get back to you.